So thank you everybody for joining us for our JBI live webinar. We're going to have a fantastic discussion by Associate Professor Zach Munn on the criticisms of evidence-based healthcare, past and present, a response and a reflection. Now, before we get into the actual presentation itself, we will just go over a little bit of housekeeping, and we do just want to acknowledge that the land that we are meeting on is the traditional country of the Kaurna people of the Adelaide Plains, and that we pay respect to the elders past and present. We recognise and respect their cultural heritage, beliefs and relationship with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. We also extend that respect to other Aboriginal language groups and other First Nations peoples. So, thank you everybody and welcome to our JBI live webinar. Now, to get the most out of this webinar, all of us have joined, except for myself and Zach, obviously, in what we term listen-only mode, which means you can listen to us talk, but you will not be able to actually turn on your cameras or turn on your mics to talk with us at the same time. However, we still want this to be as interactive as possible. And so what we can do is interact via the chat function of Zoom. So if you'd like to introduce yourself or let us know why you've joined, please do use the chat function. Now, as Zach is delivering his presentation, if you have any questions that you want to ask of him, you can do so by using the question and answer functionality or the Q&A functionality. Now, please just make sure that if you do have any questions that you ask them via this Q&A functionality and not using the chat function. Now, if for whatever reason you need to leave the webinar early or you wanted to share this webinar and this discussion with some of your colleagues who aren't able to make it, this recording will be available via JBI YouTube. If you have any feedback about the presentation, either now or after the presentation, please do let us know by emailing jbieducation@adelaide.edu.au. So without any further ado, I would like to invite Associate Professor Zach Munn to talk to us about the criticisms of evidence-based healthcare. But before he does, let's just do a little bit of formal disclosure work. Associate Professor Munn has an affiliation with the following organisations that could be perceived as a direct or indirect conflict of interest in the context or content of this presentation. Zach is the Director of Transfer Science at JBI. He's the Vice Chair for the Guidelines International Network. He's a grade working group member and the Centre Director for the JBI Adelaide Grade Centre. Zach has editorial roles for the International Journal of Evidence-Based Healthcare and BMC Medical Research Methods. He's an NHMRC investigator grant and he's received funding from NGOs, governments for SR and clinical practice guideline development and training. So what I'd like to do is now I will stop sharing my slides and I will invite Zach to begin sharing of your slides. Zach, whenever you're ready.
Fantastic. Thank you, Tim. And thank you for the invitation to speak today. I'll just confirm that you can see my slides.
Yes, we can all see.
Great. Thank you. Well, welcome everybody. And thank you for taking the time out to come to this webinar today, where I'll be discussing some of the criticisms and perhaps challenges for evidence-based healthcare, past and present, and responding to some of these challenges and critiques. And I hope that you'll all ask lots of questions so we can have a good discussion at the end as well. So this is the plan for today. We'll discuss some of the early critiques for evidence-based healthcare and clarify what we mean when we say evidence-based healthcare. Then we'll move on to the current or ongoing critiques or the modern critiques of evidence-based healthcare and responses. And finishing up today, we'll discuss some of the remaining challenges, including the challenges that COVID-19 presents to evidence-based healthcare and evidence-based medicine. But when I hear some of these critiques of evidence-based medicine or evidence-based healthcare, and I'll use these terms interchangeably today, I sometimes wonder, well, if not evidence-based medicine, what else? How can you argue against having practice which considers the best available research? So what else would we be doing? And what actually came before evidence-based medicine and evidence-based healthcare? It's always useful to go back in time and have a consideration of what actually was occurring before we started practicing evidence-based healthcare. And one of the things that we were practicing is that people would often just listen to and follow what the experts in the field said how practice should be delivered, or go on their own intuition, their own experience, and what they saw in their practice, with not a lot of reference to perhaps research or trials. And in terms of actually developing recommendations for practice in guidelines, historically the approach was what we might call the GOBSAT method, which stands for good old boys sat around the table. And this really wasn't based on evidence or research, but more so expert opinion. And contrary or opposing to evidence-based medicine, we could call this eminence-based medicine, what has always been done, and making sure that we follow what the big figures in the field say. Now, this is a bit of a blinkered view, I guess, of the past, because there were people who obviously were interested in trying to evaluate rigorously treatments and therapeutic interventions, such as James Lind. And if you're interested in the history of developing or testing medical treatments and looking at how we can evaluate whether or not a treatment or therapy is effective, I'd encourage you to go to the James Lind Library. But let's now turn to evidence-based medicine. So evidence-based medicine, the first time it appeared, the term first appeared in the literature was in 1992 in this article led by Gordon Guyatt. And this was the first time this term appeared in the literature. And in this article, Gordon Guyatt and colleagues stressed or advocated for a new paradigm for medical practice. And they said that evidence-based medicine de-emphasizes intuition, unsystematic clinical experience, and pathophysiological rationale as sufficient grounds for clinical decision-making, and stresses the examination of evidence from clinical research. This is obviously over 20 years ago now, and evidence-based medicine has taken hold within healthcare. But this was the first time that it did actually appear in the literature, this term and a definition for evidence-based medicine. And what I'd like to do now is to get some understanding or gauge your understanding and interpretation about evidence-based medicine. So I might ask Tim to start the poll, because I'd really like to see how you consider or define evidence-based medicine. So pick the most appropriate response. They may not be perfect, but what you would consider is the most appropriate response about what evidence-based medicine means to you. And we'll give you a few minutes to, or not minutes, a few seconds, I guess, to complete that poll, and then we can discuss the results. So I'm hoping that everyone's got the poll in front of them and can select from one of the 4 options. Okay, all right. So we can see the results of this poll now. Thank you to those of you who did vote. And we can see overwhelmingly that people chose option, the 3rd option, considering the best available evidence, patient preferences, local resources, and clinical expertise in delivering care. And that's what I expected amongst this audience, knowing that many of you have probably heard about this from JBI, which is and this option is very similar to a JBI definition of evidence-based healthcare. Very good, good. I'm preaching to the choir somewhat here, but I think that's good to know. What we do need to understand, though, is that many different people have different interpretations of evidence-based medicine, and maybe not different interpretations, but misperceptions, perhaps, about evidence-based medicine as well. And these have been occurring ever since evidence-based medicine was first proposed in 1992. And some authors have actually done a summary of what some of the early critiques of evidence-based medicine were in some review type articles. And I've got a summary of some of these early critiques here. So a lot of the concerns focused on the fact that evidence-based medicine seemed to put too much weight or too much reliance on randomized controlled trials, and that it was too much focus on the results of randomized controlled trials, and irrespective of any other evidence or any other factors that we need to consider. This obviously was is a big concern where there are randomized controlled trial evidence where it is not available for different fields, different professions, and in different areas. And that if there was no randomized controlled trial evidence, then that means that we wouldn't be able to practice evidence-based healthcare. Another critique was that evidence-based medicine disregards a patient or client or consumer's preferences and values and their own beliefs and their own choices about what treatments they would like to take. There was also a thought that evidence-based medicine disregarded clinical experience and expertise and the health professional's own judgment. That this was a cookbook approach to practice where everybody had to follow the exact same recipe for each patient, and that it may be a cost-cutting tool advocated for by administrators, but really just as a way to disguise ways to cut costs across the health system. And the need, while shifting to this new way of practicing healthcare, the need to actually develop evidence-based medicine skills and training, and the upskilling that would be required across the professional health profession workforce. But I think a lot of these criticisms really do come from this misperception or misunderstanding, perhaps, of what evidence-based medicine and evidence-based healthcare actually are. And many of you, I'm sure probably all of you, are familiar with the work of David Sackett. And in his 1996 editorial in BMJ, Sackett and colleagues defined evidence-based medicine and highlighted what evidence-based medicine is and what it isn't. And they stress that evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. It means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So he highlights here that it is about care of the individual patient, and we need to consider their own preferences and values. That we need to use our clinical expertise to weigh up our expertise, assess the patient, assess the evidence, and marry that with the evidence from systematic research when making decisions. And Professor Alan Pearson followed in a similar vein on this as well when he clarified what evidence-based healthcare is. And particularly that evidence-based practice is not exclusively about effectiveness, but it's about basing practice on the best available evidence. So if there aren't randomized controlled trials available, we still need to use the best available evidence. The other thing that he really stressed was that there are a lot of different types of questions that arise in healthcare, not just about the effectiveness of a treatment, but also about whether or not a diagnostic test is accurate, for example, what the risk factors may be for a particular condition, what the prognosis may be for particular conditions, and how people may interpret or experience their treatment and care as well. And that we need different types of questions and different types of evidence and research methodologies to generate this appropriate evidence for evidence-based healthcare as well. And in terms of clinical practice guidelines, at least, since GRADE has been around, we've always considered a number of different factors when forming recommendations, not just the results of randomized controlled trials, but the balance between benefits, harms, and burdens of any particular treatment strategy, patient values and preferences, and any impact on equity, resource use, feasibility, and acceptability as well. So these clarifications, I think, of what evidence-based medicine and evidence-based healthcare are really respond to a lot of those early criticisms and critiques of evidence-based medicine. And I would like to hope that we can now put this straw man to bed, that evidence-based medicine does not equal randomized controlled trials, and that this is a bit of a myth. And I would hope that in 2020 we can retire this misconception, because we know from the early leaders in this field that we say that evidence-based healthcare relies on the best available evidence. Proponents of evidence-based medicine and evidence-based healthcare have developed tools to evaluate non-randomized evidence so that we can consider the results. Systems such as GRADE do consider non-randomized controlled evidence where appropriate. We know randomized controlled trials are ideal, but we also equally acknowledge that they're not always available for decision making, or, depending on what our question is, not the ideal design as well. And we know that with current systems such as GRADE, we can still make strong recommendations even with low certainty evidence. So I really do hope that we can now put this straw man to bed. So that's a bit of a retrospective, really looking back at some of the criticisms and misperceptions about evidence-based medicine when it was first proposed in the 90s and started to take up traction and steam in the late 90s and early 2000s. But a lot of these critiques and maybe misinterpretations are continuing on. We've also seen some new challenges, perhaps, for evidence-based medicine in recent times. And this is what I'd like to run through now. So in the last 10 or so years, we've seen a lot of commentaries, editorials, opinion pieces reporting on some of the issues with evidence-based medicine, including this report to Alvin Feinstein, who was an early leader in clinical epidemiology. Such as another example is this article by John Ioannidis, which was actually a letter, a report to David Sackett, discussing how evidence-based medicine has been hijacked by vested interests and how we needed to get rid of these pirates. Then there's other articles that have also discussed issues with evidence-based medicine and how it is currently failing patients. And the issues with, perhaps clinical trials and publication of trials, and once again, vested interests as well. And one of the early leaders in the field, Professor Tricia Greenhalgh and colleagues, talked about evidence-based medicine not too long ago being a movement in crisis as well, due to a lot of the issues that have been discussed. So what are these issues? So what are some of the more modern critiques or perhaps challenges for evidence-based medicine? So summing up a lot of what these articles have discussed, perhaps one of the main critiques is that evidence itself and research is flawed. This may mean that evidence itself is out of date, that there are people who are conflicted, who are putting out these articles, and there's conflicted interests, there's vested interests, perhaps commercial interests in getting this evidence out, and the issues of publication bias. Another critique is that guideline recommendations are currently being forced upon healthcare professionals, and that this is making people slavishly follow what recommendations say, disregarding patient choice, preventing critical thought, and not allowing shared or personalised decisions. And clinicians were being penalised for not following guidelines or recommendations, even when not following them is justified. Another critique is that evidence and the results of research in particular are presented in ways that clinicians, policymakers, and the public do not understand. And here we might be seeing that small effects are misleadingly represented as larger effects, or that sometimes evidence is presented with a lot of spin and put forward perhaps even as pseudoscience from some areas. There were critiques as well that there is too much evidence, too many systematic reviews, and too many guidelines that people are producing. And there was some critiques about these warehouses or factories or production lines for developing systematic reviews, which results obviously in duplication, sometimes conflicting evidence, and a lot of waste in the generation of research. There's also been critiques that doing systematic reviews and developing trustworthy guidelines is incredibly resource demanding, that the methods are increasingly complex and not always standard, and that once we've done all of this, it's still, by the time we get it all done, the evidence is out of date. And some of the difficulties with trying to master some of the new approaches and methods becoming more and more complex. Another problem with perhaps particularly clinical trials is that the research is sometimes not seen as generalizable and not reflective of real world patients, and that the people or participants or subjects we see in these trials are not the sort of subjects or participants or patients that we see in our real world clinics and hospitals and health systems. And finally, that there's been too much investment in perhaps clinical research and not enough in implementation research, or not enough done on actually trying to get evidence into practice and trying to get findings from systematic reviews or recommendations from guidelines actually into practice, and that we need to shift our focus to actually look at implementation science and start investing more in this field, because there is still this huge gap between evidence and practice in many areas and many fields. So what I'd like to do now is try to reflect and respond to some of these critiques. And I think a lot of these critiques are valid, but I'd like to take let's say an optimistic view about evidence-based medicine, evidence-based healthcare, rather than being pessimistic about some of these challenges. So I'd like to run through these critiques and then talk about how perhaps the evidence-based healthcare community are trying to respond to these critiques for the better. So the first critique is that evidence is flawed and that much evidence is conducted poorly, and there's a lot of low quality research out there. However, proponents of evidence-based healthcare have been involved in a lot of initiatives to try to improve primary research and the way that primary research is conducted and reported as well, by developing guidance, by developing reporting standards, and by developing tools that people can use to assess the methodological quality or the risk of bias of these studies as well, which can help inform people how these studies should be conducted and what they need to address, but also help end users of research also determine the credibility of that research as well. So groups like the Equator Network, and which advocate for transparent reporting of all different types of research, and have provided a database of reporting standards for different study designs. And groups like JBI, where we've developed critical appraisal tools, which people can use to evaluate the quality of research, and people can also use when designing research to make sure that they are taking these issues into account. And of course, Cochrane as well, who have some tools also, and others. The second critique is that, or a related critique still regarding primary research and sometimes largely clinical trials, is that much research is driven by vested interests, and publication bias and selective reporting exist. And this is particularly, there's been in particular a lot of critiques of big pharma or medical device companies who selectively report results, who try to hide the results of their research, or who design studies so that they get the outcome that they want based on their commercial interests. Now, however, proponents of evidence-based healthcare have been working on a lot of initiatives to make sure that conflicts are transparent and noted in research, and to try to control and manage conflicts in research as well. and also been involved in movements such as All Trials and REAT also. And although this is obviously a problem with the generation of evidence for evidence-based medicine or evidence-based healthcare, I don't know if it's a valid critique of the evidence-based movement or evidence-based healthcare field itself. I'm not sure we should be blaming evidence-based medicine and evidence-based healthcare for the sins of big pharma. So groups, as I said, like All Trials, which are trying to make sure that all trials are registered so that we have the access to the protocols for all trials, and that all the results are also reported in full as well, so that we can get access to all of the data that was collected during a trial to reduce the risk of selective reporting and publication bias. And there are groups as well, such as REAT, Restoring Invisible and Abandoned Trials, this initiative, where they're looking at past trials which may not have been published or may have been selectively reported or abandoned, and trying to analyze and disseminate the findings of these trials. Okay, another critique is that evidence is out of date, and that by the time you do a systematic review, it's already been too long, and systematic reviews go out of date quickly. And we know that systematic reviews can take a long time. Clinical practice guidelines can also take a long time to work through. And by the time that a trial is done, and then the time it takes for that trial to get published, and then it get included in a systematic review, and then for that systematic review to get published, it's almost out of date by the time it actually gets published, according to the traditional approach to developing systematic reviews and guidelines. However, once again, proponents of evidence-based healthcare have been working very hard to develop approaches to living systematic reviews, living guidelines and living recommendations, and living evidence to try to make sure that systematic reviews and guidelines are always up to date. So new models of developing systematic reviews and guidelines are being tested and trialed and are being successful. And investing in technology and methods to support this as well, such as the Living Evidence Network and living systematic reviews. There's also groups such as ICESA, or the International Collaboration for the Automation of Systematic Reviews, and there's a lot of groups who are trying to develop tools to either streamline or automate the systematic review and clinical guideline development processes so that we can get these done in shorter timeframes, such as using systems like JBI Summary or other tools. And there's groups such as GenTech, which are also invested in looking at these tools as well. So we are doing our best to try to make sure that evidence is synthesized more quickly, and that we can make more recommendations in a quicker fashion, and make sure that these are always up to date. So another critique is that guidelines are forced upon clinicians, and there's a feeling that guideline recommendations must be slavishly adhered to, disregarding expertise and individual preference. But from an evidence-based healthcare perspective, in fact, a lot of people working in evidence-based healthcare promote and encourage shared decision-making, and new guideline development processes really focus on the importance of shared decision-making. So in some of these new guideline development methodologies, there is really clear guidance on how recommendations should be adopted or followed. Not saying that everyone should follow every single recommendation, disregarding everything else. So particularly, as I mentioned about shared decision-making, which really is perhaps the most important endpoint of an evidence-based decision-making process, that the patient themselves considers is well informed about the benefits and harms, and then works that through with their healthcare professional. And like I said, in terms of the way we should be interpreting recommendations, whether they be strong or weak in clinical guidelines, here's the guidance from GRADE about discussing the importance, particularly for weak or conditional recommendations, that we need to use decision aids, and that we need to engage in shared decision making. Another critique is that evidence is presented in a way that readers can't interpret, or that sometimes perhaps there is a lot of spin involved, with perhaps small effects portrayed as large and very meaningful effects, and that end users struggle to understand research. Policymakers, decision makers, patients, consumers, etc., can't understand all the research. However, once again, proponents of evidence-based healthcare and evidence-based medicine have been really invested in trying to improve ways to communicate or transfer evidence into the hearts and minds of those who will use it. And they've led the development of decision aids and shared decision-making movements, which have grown a lot in the last 20 or so years. And of course, also stress the importance of communicating absolute risks from research as well, which we know are easier to understand than perhaps relative risks. And a really interesting example of perhaps people presenting research results incorrectly just happened earlier this week. And there's a Twitter account called Relatively Risky, which highlights some of the ways that the results of research are presented, particularly in the media, which often focuses on relative risks rather than absolute risks, which are more important really for decision making. So just to highlight what we mean here by relative risks and absolute or absolute risks as well. Here in this example, when we're talking about relative risks, in terms of this intervention versus control or comparison, we had a relative risk, which was an odds ratio of 0.59, which is quite difficult for end users to interpret. But in great approaches and other approaches in evidence-based healthcare, we stress the need to actually present this in a way that people can interpret, such as in natural frequency, so that a risk for experience a particular outcome with one treatment option, such as here, is presented using natural frequencies, such as how many people out of 1,000 will experience that, compared to how many people out of 1,000 will experience that with the comparison intervention, which is much easier for most people to interpret. And this sort of information can then be presented in different ways, including the use of icon arrays, which can be very useful in shared decision making as well, such as in this decision aid here, where we can see the risk, and it's displayed graphically. We can see the risk of having a heart attack for a particular person based on their risk profile using standard dose statins, compared to those who do not medicate for heart problems. And presenting information in this way, once again, makes it a lot easier for people to interpret. And then taking this forward as a full decision aid, we can also start looking at the benefits and harms and the burden of a particular treatment strategy. So what the side effects might be, in addition to the potential benefits in reducing the risk of a heart attack, impacts on costs, impacts on our daily routine or the treatment burden, etc. And this is a lot of people in evidence-based healthcare are working on developing these types of evidence-based decision aids to promote shared decision making and help people to understand the results of research. Okay, another critique is that there is too much evidence, too many guidelines and too much duplication, and that much research, systematic reviews and guidelines are not needed or unnecessary. Once again, proponents of evidence-based healthcare are trying to stress a need for trial and for systematic review registration, and also for guideline registration as well, and develop systems to adapt or adopt guidelines to make sure that we are reducing duplication and reducing waste in research. And there's a lot of initiatives which are very closely aligned to evidence-based medicine and evidence-based healthcare, such as the Reward Initiative and EBHC. So Prospero, for example, which I'm sure most of you are familiar with, which is a register for systematic reviews in development, so that prospective systematic review authors can go on and see if someone else is actually going to do a systematic review on a same topic or similar topic, which might mean they don't need to do it, or they might be able to collaborate with those authors. And as I mentioned, there are systems now for adopting or adapting guidelines produced by other bodies for local contexts or local populations as well, so that you don't need to do the whole guideline development process from scratch, therefore reducing waste and perhaps streamlining the development process. And as I said, the reward initiative and EBHC, which are about making sure that we use evidence to inform research and that we reduce research waste and improve the conduct of research. And in terms of guideline registration, guidelines can also be registered. Prospective guidelines can be registered in registries such as the Gin Library. Now, another critique is that methods are getting too complex and too demanding, time demanding, and it's getting too difficult once again. However, proponents of evidence-based healthcare, once again, similarly to the last critique, do stress the need for sharing data to reduce effort and provide education and workshops regarding the methods and the ways to practice and conduct evidence-based healthcare. And stress the need for standardization as well, so that we are we don't need to learn about so many different tools, and also that we can perhaps conduct our assessments or our interpretations of evidence in standard formats, which can then be shared with others, so that we're once again reducing duplication. And at JBI, for example, we have a lot of educational courses about how you can conduct systematic reviews and develop guidelines and implement evidence as well. And Evidence-Based Medicine on Fire, which is a group which is trying to look at standards for producing, analysing and synthesising evidence, so that this work can actually be shared across systems, once again reducing duplication, so that there's not so much investment by individuals, but we can share the work. And then another critique is that research is done on ideal and not real patients, and that clinical trials in particular focus on patients, not the complex patients or patients with comorbidities that we see in the real world, but because they're trying to achieve high internal validity, they might focus on simpler patients, for lack of a better term. But proponents of evidence-based healthcare highlight the importance of pragmatic trials and the importance of addressing complex patients and patients with comorbidities in guidelines. And pragmatic trials, I don't think I have time to run through this today, but pragmatic trials make sure that these trials are done in real-world settings for real-world uptake and ensure that the patients included in these trials are reflective of those we see in our own settings. And there's even a tool developed called Precise2, which you can use to evaluate whether or not a trial is pragmatic or more explanatory. And there are groups working on multi-morbidity, comorbidities, all of these sort of issues in guideline development too. And perhaps the final critique here is that there's been too much investment in clinical trials and other types of research instead of actually focusing on or investing in ways of changing practice and making sure that evidence actually does get into practice. But once again, there is a field of implementation science where people from evidence-based medicine and evidence-based healthcare are stressing the need to get evidence into practice and investigating the science of evidence implementation to try to make sure that we can get evidence into practice. And there are some fantastic journals which really are just completely devoted to implementation science, such as Implementation Science, or the newly relaunched JBI Evidence Implementation as well, which focuses purely on evidence implementation. So that's my response to some of the modern or current critiques. And now I just want to reflect, if you will allow me, for a few more minutes on some of the remaining challenges and perhaps future evolution of evidence-based healthcare. And a really interesting article was published recently by Professor Tricia Greenhalgh, once again, about whether or not evidence-based medicine will survive COVID-19, and that how COVID-19 is really testing evidence-based policy making and evidence-based decision making, which has been really interesting. And when we look at evidence-based medicine during a pandemic or urgent or critical situation, we need to consider, well, what does evidence-based medicine actually look like in this kind of scenario that we're facing at the moment? You know, perhaps it does act actually as a safeguard against potentially ineffective strategies such as hydroxychloroquine, or is it actually acting as a barrier perhaps against potentially effective treatments such as face masks? What I really think we need to always consider and keep in mind is the principles of evidence-based medicine and evidence-based healthcare, which we've talked a little bit about today. Now, we should always be wary of conflicted interests or vested interests as well. And people perhaps misappropriating the term evidence-based medicine or evidence-based to argue against particular treatment strategies based on their own beliefs or prejudices. So we always need to be aware of that. We also need to acknowledge and address uncertainty. There is often a lot of uncertainty. It's not often that we have high certainty when trying to form recommendations. And we need to be aware and address and acknowledge that, yes, sometimes we do have some uncertainty in the evidence. We should always make sure that we are focusing on benefits and harms as well, and not just focusing on the benefits, and use the best available evidence. So we can't always rely or wait perhaps for high quality randomized controlled trials. But we also need to make sure that we do rally against pseudoscience and snake oil treatments. And a really, really fantastic Twitter thread explaining this article from Professor Greenhalgh on Twitter, where she mentions how evidence-based medicine, narrowly defined and applied, is not perhaps the best way we should be practicing medicine in the 21st century, particularly in a pandemic. As in, if we wait or don't act until we have randomized controlled trial certainty or randomized controlled trials, this could actually be a really big issue. So it's interesting reflecting on this, about this narrowly interpreted or narrowly defined evidence-based medicine, or what has sometimes been called rubbish evidence-based medicine as well, and the need to return to real evidence-based medicine. And it does show that people still do have these misperceptions, at least I think anyway, about what evidence-based medicine, evidence-based healthcare is. And are still perhaps trying to misappropriate the term for their own interests. And from my own perspective and our own perspectives, perhaps they have some impact on the way that we define evidence-based healthcare and evidence-based medicine. And my own perspective as someone who was trained as an allied health professional and who's worked at JBI, which has always had a pragmatic and inclusive view of evidence and the best available evidence, and as an evidence-based healthcare advocate, I would agree completely that we do need to retire and get rid of this myth of this narrowly interpreted version of evidence-based medicine. So another interesting thing that I thought would be useful to touch on this webinar is whether or not evidence-based medicine has actually evolved. And if we look back 20 years ago, even in that article by Gordon Guy and in the article by David Sackett as well, they did talk about some of the key tenets of evidence-based medicine. But I thought it'd be useful to say, well, has evidence-based medicine evolved? Well, of course, a lot of initiatives have evolved over time, but I thought it'd be interesting to see what Gordon Guy, who coined the term, thought about this. And in this interview that he did relatively recently, he mentioned that it has changed somewhat over 26 years in the way we define or consider evidence-based medicine, particularly the issue of values and preferences. And that the issues of values and preferences is now very much more important within evidence-based medicine than it was in the beginning, and that the evidence-based healthcare and evidence-based medicine communities are putting a lot more focus and attention on some of these issues. which is, of course, makes those critiques those early critiques not valid. And this also brings me back to our work at JBI, where we've recently tried to provide a new definition for evidence-based healthcare, reflecting this evolution as well, along with a new model for evidence-based healthcare, where we've said we define evidence-based healthcare as decision-making that considers the feasibility, appropriateness, meaningfulness, and effectiveness of practices. We can't just focus on the effectiveness, but we need to consider the feasibility, appropriateness, meaningfulness, and effectiveness, which we sometimes refer to as the FAME approach. The best available evidence, the context in which care is delivered, the individual patient, and the professional judgment and expertise of a health professional inform this process. And I think this reflects JBI's approach and really the thinking internationally about evidence-based healthcare now. And another sort of concluding thought today is that a lot of the critiques or perhaps challenges that we've discussed have actually been identified by leaders and workers in the field or in the movement of evidence-based medicine and evidence-based healthcare, which I think is really very healthy and very, very transparent. So I think we are aware of these challenges and we're striving to address them as a community. One of the things that we need to also address as a community is what are the valid critiques and challenges from the straw man arguments, the misinterpretations and the misappropriations of the term, which we need to carefully defend against. And once again, just demonstrating that some of the leaders in this field are really driving the improvements and responding to some of these challenges. A group led by staff at the Oxford Centre for Evidence-Based Medicine have put out an evidence-based manifesto for more trustworthy evidence and evidence-based healthcare. So just summing up today and discussing some of the challenges and remaining critiques and what's next for evidence-based medicine and evidence-based healthcare, I think some of the critiques are still ongoing challenges for evidence-based medicine, which we need to continue to address. We also need to make sure that we are correcting these narrow interpretations of evidence-based medicine because they do still persist. And we need to make sure that we are doing awareness raising and teaching and training and education so that people do understand real evidence-based medicine and evidence-based healthcare as opposed to rubbish evidence-based medicine and healthcare. We need to always, I guess we need to be comfortable with uncertainty and knowing that we won't always have high certainty evidence. And we also need to acknowledge complexity in the way we think about applying evidence and perhaps generating evidence as well. In the times that we live in, particularly, we need to be worried about pseudoscience and this post-truth world which you're operating in, and this is a challenge for evidence-based medicine. We need to keep the effort and focus on improving implementation and uptake of evidence in practice. And we still need to do further work on over-treatment, over-diagnosis, too much medicine, and from people trying to hijack the term evidence-based medicine. So that is my presentation today. I hope you've all found it useful and worthwhile, and I hope we can have some questions and answers and discussion now. But if anyone has any questions about the work we do at JBI or the presentation today, please, you can contact me at my email or on Twitter. Thank you.
Okay, thank you very, very much, Zach, for that really engaging presentation. Now, we do have a few questions. Can you see the question and answer, or would you like me to read them out to you?
Yes, that'd be, if you could read them out.
Okay, so in terms of evidence-based practice across different types of health professionals, are there certain types of practitioners who implement evidence-based practice to a greater or lesser extent?
Okay. Great, well, that's a really good question. And the answer is yes. In terms of the actual uptake of evidence into practice, we know that in particular fields and for particular specialties, there are some people who are more compliant with evidence-based recommendations compared to others. And if you look at from an Australian perspective, the care track studies really go into into this in more detail and show that for some recommendations there is quite high uptake, you know, in the 90% percentiles, but for other areas there's perhaps a much lower uptake of evidence in practice. This may be differences across professions, but also within professions in different disease areas or domains of practice as well. So there is a lot of variation, but I don't want to highlight any particular profession at the moment. But there is some good research which is investigated the uptake of evidence into practice.
And we have another question. Do you think in terms of pragmatic trials and ensuring that trials are appropriately reported, should the responsibility be on research institutions such as universities or the publishers themselves?
Okay, so I think this is a really good question. I think there's a shared responsibility here, going right back to institutional review boards or ethics committees, and through to the eventual the authors and the publishers as well, and perhaps any funders or regulators also. So the real responsibility to publish, I think, does remain with the authors or perhaps the sponsoring body in terms of the quality and making sure that people do the trials well. I think that even does come back to perhaps institutional review boards, funding bodies, and the authors themselves. Hopefully that's answered your question. I know that if you look at the work from all trials, there has been some work by Ben Goldacre and the team who have looked and they investigate groups who don't publish their trials. So, and I think actually one of the biggest culprits was obviously there's issues from the pharmaceutical industry, but another culprit was a lot of universities. There's a lot of trials conducted by university staff, and there was actually relatively poor compliance, I believe, from actually publishing those trials. So they were following up with a lot of universities to make sure that those results were available and reported.
Now we have another question. I'm wondering how you see the advent of digital health technologies impacting upon evidence-based medicine in terms of possible benefits and challenges.
Okay, so I think this digital revolution in health, there's a lot of opportunities and for evidence-based medicine, evidence-based healthcare. I think there's a lot of opportunities in terms of the rollout of electronic health records and in terms of clinical decision support as well, which I think will really improve healthcare. I think different digital health technologies such as monitoring systems and tracking systems and wearables, etc., might have some role to play. And certainly there's been some interest in how these might contribute to big data and real world evidence. The issues are, of course, that we need to make sure that whatever data we're collecting from these wearables or big data, that we still need to make sure that it is collected appropriately, and we need to look at issues regarding the validity of that as well. So I think there's going to be a big impact on research itself and potentially evidence-based medicine as a field, of course, as well. But we need to not get perhaps carried away by some of the sales from some of the messages and salespeople of some of these things in terms of the wearables and big data, and always need to keep some of these principles about evidence-based healthcare intact, that we always need to assess the credibility of any of this research and results.
Okay, and I think we have time for just one more question. Given how much easier it is to get funding to further existing evidence bases, do you have any tips for making fast and workable inroads into arenas where there is currently a noticeable lack of evidence?
So that's a good question. Getting funding is always tricky. One thing that I've been impressed with recently, and it's only been for a few years now, is this commitment from a lot of funders such as NHMRC or the National Institutes for Health Research in the UK or the Canadian Institutes for Health Research. They're stressing the importance to justify any further trials or studies, particularly, or funding for any further trials or studies, by showing that there is a real evidence gap by normally conducting a systematic review and using a systematic review to show where the gaps in the evidence are, or trying to justify why funding is very much needed because there is no clear answer. I think is a really important approach, and I'm really glad to see that some funders have started encouraging people or even forcing and mandating that if you do want to go for clinical trial funding, you have to clearly show that there is no trials or no clear evidence yet in that field, which I think is a noticeable lack of evidence, as you say. Do I have any tips for making fast and workable inroads into arenas where there's currently a noticeable lack of evidence? No, I don't think I do at this stage. But like I said, I think it is using evidence synthesis approaches to show that there is a lack of evidence in a particular area can be a useful tool to help justify or get funding, convince funders.
Thank you, Zach, once again for this wonderful talk. I just want to note that our next JBI live webinar will be hosted by Dr. Kylie Porritt, who is chair of the JBI Implementation Methodology Group and senior researcher at JBI. Kylie will be joined by Alexa MacArthur, and they will be discussing a practical approach to providing implementation in research and healthcare settings. So thank you everybody for joining Zach today, and we hope to see you next month for our next webinar.
Great, thanks Tim. Thank you everyone.